I will be summarizing the data for brexpiprazole, describe the efficacy and tolerability, and do that for schizophrenia, although you are aware that brexpiprazole in the United States is also approved as augmentation for unipolar depression, as is aripiprazole. So I will start with ideally looking at what should a new antipsychotic cover in terms of needs. The pharmacology of brexpiprazole you've already heard very elegantly described, so I will skip that. And then I'll go into the acute and maintenance studies, and then finish up with translating the clinical trial data into clinical practice. So when asking ourselves, why do we need new antipsychotics? I think one answer is because schizophrenia is quite heterogeneous. Not everybody will respond to the same medication. And while there were lots of cascades being shown on the slides, I think we don't fully understand what is the disturbance for each individual patient and where might a certain combination of receptor blockades or partial agonism, downstream effects, then converge on helping some patients more than others. But we want a balanced pharmacologic profile, more on the efficacy side and dialing down receptors that could be responsible for side effects. We want to not only treat psychosis in terms of positive symptoms, but also look at other symptom domains like negative symptoms, depression, ideally cognition. We don't need to stop after the acute phase. We need maintenance treatment, protection against relapse. And the benigner, the more benign the profile is, hopefully, the more likely will people be to continue with the medication, because ultimately what we want is recovery and functional improvement. So I will go through the approval studies. There were 2 acute studies that were identically designed, and they were 6-week studies. 2 and 4 milligrams were the active doses, and then there was an attempt to see what is the lowest possible dose. In one study it was 1 milligram, and in the other one it was a 1/4 milligram. And then there was also a relapse prevention study. So here again, the acute phase studies, identically designed. Patients were screened, washed out, and then randomly assigned to 2 or 4 with titration. So for the first 4 days, everybody received 1 milligram. Then for the remainder of the first week, it was 2 milligrams. And then either people stayed after 1 week on 2, or they went to 4 milligrams. As I mentioned, 2 lower doses were explored, but they were not effective in either of the 2 trials. Here are the 2 studies next to each other. In one study, the 4 milligram dose separated, the 2 milligram dose did not, and the approval, however, is for 2 and 4 milligrams because in the second study, both 2 and 4 milligrams improved patients with schizophrenia better on the PANSS total than placebo, with a separation as early as week 1. So when pooling together the 2 studies and having more power and less variation, then the 2 milligrams and the 4 milligrams separate from placebo. But you already see that there may be an advantage of the higher dose. And since, as I will show you, brexpiprazole is very safe at these doses, clinically the question arises, did the trial program stop too early? Did they look only at 4, and should they have gone higher? are there some patients, as you saw in the pharmacology talk, that might actually need a higher dose in order to occupy more receptors so that the partial agonism might not be too much in this patient population. Although we believe that brexpiprazole has a more reduced partial agonism than, for example, aripiprazole or cariprazine. Now, total symptoms are a gunshot approach. We obviously need to look further into other symptom domains. We want to treat positive symptoms for sure, but what about negative or disorganized symptoms? Patients obviously were not terribly hostile and uncontrolled because they agreed to a randomized placebo-controlled trial. But even with less severe baseline symptoms, both doses separated also for hostility and excitement. There has been sometimes the thought, oh, partial agonism is partial efficacy, doesn't really work for aggression. Well, at least in this trial program, there was also efficacy. But you can also see that in most outcomes, the 4 milligram dose seems to be a little bit ahead of the 2 milligram dose. Now, patients were not selected for having anxiety or depression, but that can be comorbid. And despite lack of power, because only a subgroup had depression and anxiety, both doses significantly improved these conditions. Now, we have to consider, though, that these might be secondary depressive symptoms, secondary negative symptoms that improve when positive symptoms are reduced. So the moment that somebody doesn't hear that many voices, is not as suspicious and withdrawn, will talk to the team again, that might be a secondary effect and not primary. But where the rubber meets the road is not in symptom reduction. It is in functionality. And obviously, these are acutely ill patients where hopefully a reduction in symptoms will also improve functionality. But this could be shown, as you see here, in all three main areas of functionality. Social activities, socially useful activities, so that people were more engaged, personal and social relationships, and also self-care. Clearly, the disturbing and aggressive behaviors were lower, so less power. And you can see that in those 4 areas of the PSP, the personal and social functioning scale, the 4 milligram dose was significantly better in all 4, the 2 milligrams only in 2 areas. So again, lending some further support that unless somebody has side effects at 2 milligrams, you most likely need to go up to 4. What about acceptability? Discontinuation rates have been used for that, and you can see that the discontinuation overall is pretty low for the 2 and 4 milligrams, and the highest for placebo and the lowest dose of brexpiprazole. Obviously, we need to balance efficacy with safety. So what are the side effects? Around 60% of patients had at least one side effect. And you can see that there's basically no side effect that is significantly larger than placebo and more than 5%. So in general, the Food and Drug Administration has a table in the package insert in the United States where it's more than 5% and double. For brexpiprazole, that table was empty. So they had to change the rules because you can't show an empty table suggesting that there are no side effects whatsoever. So they had to go down to 2% in order to have something in that table. But it just shows you that at least at 2 and 4 milligrams, this is very safe, even though insomnia is maybe 11%, but it's not higher than placebo. Headache is not higher. Agitation And you can see that akathisia at 4 milligrams is identical to placebo. And then there's a 2.3%, 2 out of 100 more on the 4 milligram dose. So that's a very low rate. We know that mood disorder patients are more sensitive. I mean, aripiprazole has maybe akathisia rates of 15% in schizophrenia, but close to 25% in mood disorders. And brexpiprazole shows also very low, below 10% of akathisia in the mood disorder range. So it's really an improved aripiprazole and brexpiprazole in that domain, which had been a little bit of an Achilles heel for some patients who really had restlessness on a partial agonist. Now, whenever you see low akathisia rates, you have to see, well, is it somewhere hidden? And you can see that even in restlessness, there are no big surprises. Whereas for cariprazine, as the prior speaker has shown, there were 5% on restlessness in addition to the 14% that had been seen for akathisia. So overall, a very stable side effect system without too much activation or sedation, which might help functionality in the long run. But if you have an antipsychotic without too much sedation, you may lack some of the additional impact in acutely exacerbated patients, where clinicians often reach for more sedating agents, like, for example, olanzapine. But like with aripiprazole, adding a benzodiazepine for the first 5 or 10 days can easily then provide targeted sedation when you need it, and then you can withdraw it when the partial agonism and net effect on dampening dopamine tone has fully set in. What about EPS? You can see, at least measured with the Simpson-Angus scale, with the Ames and the Barnes akathisia scale, there seems to be no big movement, which is good news. Prolactin, it is interesting, with aripiprazole, you would have seen quite a bit of lowering of prolactin. And here it's just a little bit, giving you again indirect evidence that brexpiprazole has less intrinsic activity and partial agonism, which is what Dr. Kikuchi, who developed both aripiprazole and brexpiprazole, wanted. He wanted to dial down some of the partial agonism, bring up a little bit more of histaminergic blockade, and also increase 5-HT2A in order to have a more balanced side effect profile. And I think he was successful with that. What about weight? So over 6 weeks, about a kilogram increase. You can see that there's a 5% greater rate of people gaining at least 7% of weight. Patients are often admitted. So basically, relatively low rates. Obviously, we will have to look at the long-term study to verify the safety of this medication. Since there was relatively little weight change, there's also no signal that we would be worried about in the glucose and lipid parameters, both as continuous outcomes and change, as well as when looking at outliers and shifts from normal or borderline to high numbers for glucose abnormalities, and the same is true for lipid abnormalities. So we have a medication that is pretty balanced in the side effects and has improved outcomes even over already pretty safe medications like aripiprazole. So here again, the shift table for cholesterol and triglycerides. You can see the numbers are almost identical with placebo. But as I mentioned before, efficacy and safety for the first 6 weeks of treatment are a good starting point, but we need much more. We need long-term efficacy and safety. So here is the design of the Equator study, trying to keep people stable. And you can see that there was first a screening period, and then there was either a conversion or continuation. There was a conversion phase from whatever they were on to Brexpiprazole. And that conversion was left to the investigator, either switch within a week, 2 weeks, 3 weeks, or a month. So they had a 4-week period, and I will present you with the analyses what period of switch actually did the best in the last section. But after the switch or starting, patients were then single-blindly stabilized on 1 to 4 milligrams of Brexpiprazole, and then after they had been stable for these 3 to 9 month period, after 3 to 9 months of treatment, they were randomly assigned to either stay on the dose that made them stable in a fixed dose design after clinicians were able to find the right dose, or go to placebo in a 1-to-1 randomization scheme. And here you see the results that aripiprazole and cariprazine had about a 50% reduction in relapses. Here you see a 71% reduction in relapse. So a pretty strong effect, and not just early, but also continued, keeping people more stable on the continued Brexpiprazole treatment than after switching to placebo. If you look not at the Kaplan-Meier, but at the actual relapses that occurred, it was a 13.5 versus 38.5% relapse. That's a very strong effect. Basically, you have a 25% difference, and that is akin to a number needed to treat of 4. So after each 4th patient, you continue on Brexpiprazole, you prevent 1 relapse, which is a very strong effect. But now we have up to 52 weeks of side effects that can evolve and develop. So how safe was Brexpiprazole? Is the early short-term signal confirmed in the long run? And you can see we had about 60% of people with at least 1 side effect in the short-term studies, and the same is true for the long-term study, both in the conversion phase, which was 3 to 9 months, and then in the 1-year phase. And you can see again that the rates are very low. Since patients were also converted from other medications, there could have been maybe some rebound from prior histaminergic blockade. There could have been also some sensitivity in some patients. So instead of 6.9%, it is 9.1%, but most people stayed in the study. And then, after the adjustment to Brexpiprazole, the akathisia rate over 1 year was just 1%. Obviously, these are people who have tolerated the medication initially, but this is quite astounding how low the akathisia rate was. Now we look at weight changes not over 6 weeks, but over the first 9 months in phase B in dark. And you see there's another maybe half a kilogram to a kilogram, but then in the long run, patients either stay the same or lose weight. So again, showing that even in the long term, this medication is very well tolerated. We know that on placebo you can lose weight because the medication is stopped, but even almost 10% of patients on Brexpiprazole also lost weight in the long-term study. So summarizing the clinical trial data before translating that into clinical practice, both 2 milligrams in 1 study and 4 milligrams in 2 studies demonstrated statistically significantly better improvement than placebo in symptoms of schizophrenia, total symptoms, positive, negative, anxiety, agitation, depression. Few patients discontinued the medication due to side effects, and the side effects were generally comparable to placebo, with very, very few exceptions. And those were in the 2% range. As maintenance treatment, again, the data for acute study results are replicated, and the reduction in risk of relapse is actually up to 71%, and the safety data are replicated even in the long run. But what does that mean now clinically? So this is the study that I mentioned, looking at the 4-week transition period. So clinicians, it's not randomized, but were able to either stop after a week in red, after 2 weeks in green, 3 weeks in blue, or take the full 4 weeks of overlap. And you can see that in this real-world approach, as we would expect, coming from full antagonists to a partial agonist, from more histaminergic and cholinergic blockers to an agent that doesn't block these receptors, a longer overlap and longer switch period was statistically and clinically much preferred. Clearly, we need to consider efficacy and safety when making treatment decisions, and having less impairing side effects is, I think, important, because when patients have a response and have less symptoms, but still feel they're not themselves because of sedation, cognitive dulling, muscle stiffness, sexual side effects, they are not really eager to continue the treatment. So having a medication that has less of that and also improves quality of life while being antidepressant in action, I think that is important. Because we know that quality of life is the lowest not in people who have residual positive or negative symptoms. It is the highest in people with depression. So having agents in the mix, and there are some antipsychotics that have that potential that are antidepressant, is important. Which are these medications? It's all 3 partial agonists, A, B, C, aripiprazole, brexpiprazole, cariprazine. We have quetiapine, lurazodone, and maybe low-dose amisulpride. How much clozapine also treats depression is a little bit more debated. But the other medications either keep depression untouched or can actually make it worse when you block too much dopamine. And we need to consider not just the objective aspects of safety risk as a clinician, but the impact that side effects can have on patients' quality of life. And when you ask family members what impairs the quality of life of their loved ones with schizophrenia the most, they say sedation, weight gain, EPS, cognition. And when you ask patients, they say weight gain, sedation, cognition. So we want agents that do not have these side effects too much, because otherwise patients with side effects will stop the medication. And you can see that here. That's why we use second-generation agents the most, because the reduction of adherence is the strongest when people feel that they can't move both physically and mentally. But also metabolic, sexual and neuroendocrine side effects, sedation, and GI effects can really reduce adherence. So where does brexpiprazole sit in comparison with other medications when it comes to akathisia? Here are data from Lesitrum, where you can see that in addition to quetiapine and iloperidone, which are quite neutral, brexpiprazole doesn't have a significantly greater effect than placebo. The highest are seen here with lurazidone and cariprazine, which has very little 5-HT2A blockade and the same partial agonism as aripiprazole. Clearly, risperidone, olanzapine, asenapine, and even aripiprazole can cause akathisia that is higher than with placebo. Sedating effects, as I mentioned, can impair people's quality of life and medication taking, and brexpiprazole doesn't have any more sedation than placebo, which in the long run is a strength, but again as I mentioned, when people are acutely admitted, some might need some additional sedation in the first days or week so that they can improve until the further dopamine blockade has set in. So here again, data from Lescitrum parsing the antipsychotics in different classes. So there are those that are predominantly activating, lurazidone and cariprazine, those that are predominantly sedating, mostly the penes that have a lot of histaminergic blockade. There are those that are similarly activating and sedating, risperidone and aripiprazole. And two medications are relatively stable on either end of the spectrum, and this is brexpiprazole and paliperidone. Clearly, treatment is a dynamic process. Switches offer an opportunity, but also a risk. When a new medication comes to market, it should not be used for those that have not responded to 4 or 5 other medications. This is not clozapine. This is another safe medication which you could use early on in treatment to set people on the right step and stage where they have a response possibility without too many side effects. And it is for people who have shown response but can't tolerate the medication as well and might therefore be less adherent than desired. So we want to engage in a shared decision-making model and starting early with medications that do not have too many side effects might be helpful. So let me conclude to give time for discussion. Brexpiprazole has shown efficacy in the treatment of patients with acute schizophrenia as well as for maintenance treatment. It is very well tolerated, arguably at the moment the safest antipsychotic until another one will be approved likely next year called lumateperone, which might have even lower side effects, but the differences are relatively small. It has low incidence of somnolence, sedation, and activation, including akathisia, and very small cardiometabolic effects, even in the long run, which is obviously desirable. Switching requires consideration of the lack of sedation and its partial agonism, but overlapping switches, like with aripiprazole, are likely most effective and desirable. So we have another tool in our toolbox, and once this medication becomes approved in Italy, you will also be able to see where it might sit and fit with your patients.